the United States. She completed her fellowship at Mount Sinai in New York. She's has a really broad and active interest in minimally invasive treatments for venous disease, including women's health interventions and uterine artery embolization. And so she's going to be talking to us today about interventions for postpartum hemorrhage.
Thank you
Welcome.
so much, Michelle, for that great introduction. It's really a pleasure to be able to talk to all of you today. I'm going to be talking about the endovascular management of postpartum hemorrhage. I'm, of course, I would like to answer as many questions as you guys have. Feel free to, I guess, put it into the chat as we go along, and I'll try to stop periodically to try and answer things as they come across, but we'll probably reserve more time at the end for questions. All right, so I'll get started. This is just an image of our hospital here in DC. So what I'm hoping to accomplish with this talk is just to describe some of the risk factors and the just sort of describe what obstetrical hemorrhage is. It's a very common cause of postpartum maternal mortality worldwide. Despite, just a lot of treatment opportunities in a very, like both surgical and non-surgical, it still remains a very large problem. We're going to also review some relevant arterial anatomy, review some of the techniques available to us for endovascular management of this type of hemorrhage, as well as what the outcomes and complications are associated with endovascular management of obstetrical hemorrhage. I did also want to spend some time talking about long-term sequelae after endovascular treatment, specifically fertility. This is a question that often comes up when we're dealing with these types of patients here in the United States. Sort of in the emergency setting, when we're talking about life and death, this is less of a question, but ultimately, people are always asking both afterwards and even during, what impact will this have on my future fertility? So I did want to spend some time talking about that. Okay, so we can just start here. So postpartum hemorrhage is a very huge problem worldwide. It's the cause of approximately 25% of maternal deaths, and it is the leading cause of peripartum hysterectomy. There are some studies, and it sort of depends on what source you're looking at, but approximately 14 million cases of postpartum hemorrhage occur every year. Specifically in Bangladesh, there are approximately 320 deaths occurring for every 100,000 live births. In that cohort, approximately 28% of those deaths are related to bleeding. Worldwide, in the peripartum period, is 1%. In terms of disease-specific morbidity, like of all potential postpartum complications, including sepsis, hypertension, abortion of the fetus, etc., hemorrhage has the highest morbidity, as you can imagine. So to define postpartum hemorrhage specifically, it is defined as blood loss greater than 500 cc's within a 24-hour period following vaginal delivery. And if the delivery is performed via cesarean section, we're looking at slightly larger numbers, over 1,000 cc's of blood loss over a 24-hour period. This is an example of a CAT scan that was done on a woman who had recently given birth, and this is done with contrast, and we're seeing contrast extravasation in what is the sort of postpartum uterus. There's blood accumulating there. So you can sort of categorize postpartum hemorrhage in two separate categories, primary and secondary. Primary occurs within 24 hours of delivery, and secondary is sort of a delayed presentation. It's, you know, it's difficult to say what significance this has. You know, you don't need to really make that sort of distinction most of the time. I think when we're talking about secondary postpartum hemorrhage, we're talking about patients who have undergone some sort of surgical intervention. So we're talking about patients who have had cesarean section, for example, and so they are at higher risk of developing pseudoaneurysms. Specifically, and so you should maintain suspicion for bleeding for women, not just in the immediate postpartum period, as in like in the hours or day after giving birth, but also afterwards, especially in women who are giving birth by C-section. So the known etiologies of postpartum hemorrhage are the 4 T's. So tone, thrombin, trauma, and tissue. So we're talking about uterine atony, which is when the muscle just stops contracting. That is by far and away the most common cause of obstetrical hemorrhage. Then there's also retained tissue, so retained placenta, membranes, blood clots, that can sort of precipitate bleeding if not removed properly. Then there's also genital tract trauma or uterine rupture. Very common, I mean, at least for the genital tract trauma. Perineal tearing is not uncommon post-delivery. And generally speaking, this can be managed with just immediate surgical intervention, but when not, uterine embolization can still be helpful in that setting. And then of course, coagulation abnormalities in these women, once especially, so if they have an underlying coagulation abnormality, that's one thing, but also sometimes when they start bleeding, they can sort of, descend into DIC, for example, and then that sort of, compounds the bleeding situation. And like I mentioned earlier, pseudoaneurysm is something that you should take particular care to be mindful of, especially in women who are post-cesarean deliveries. So in the setting of secondary postpartum hemorrhage. In the majority of cases, there's no, you really can't pinpoint any particular risk factors, so you can't necessarily say preoperatively or pre-delivery that a certain patient is at greater risk than another for postpartum hemorrhage. But in general, you do see that women who have history of multiple births, or have a multi-fetal pregnancy, or who have a history of fibroids, or who have especially history of abnormal placentation or history of prior obstetrical hemorrhage, these are all women who have higher risk of developing hemorrhage. And I didn't put this on here, but C-section in and of itself is another risk factor. So, when a woman, at least in the hospital setting, is, considered to be at risk, or is, developing an abnormal amount of bleeding, there are, there's a lot of medical management that can occur before anything more aggressive has to take place. And so, there is preventative things that can be done for example, giving oxytocin, clamping the cord, or like even, sort of pulling traction on the umbilical cord. All of these things can sort of reduce the risk from the start. There are a number of medications that are given to treat specifically atony, and they're listed here. Prostaglandins, misoprostol. So where the radiologist will come into play is when we have a patient who is bleeding despite these interventions. I would say that if there's a concern for uterine rupture, or bladder injury, these types of things, then maybe a surgical approach is more appropriate. But in a woman who has persistent bleeding or who has some sort of coagulation abnormality or is not, particularly in those who have stable vitals, but even in those who don't, the recommendation would be for endovascular management. So other things that are done, and I'll sort of go into some detail about this, balloon tamponade. So here on this image, you can see what is a Buckery balloon. That's a balloon tamponade device. It is inflated into the uterine cavity in order to provide tamponade internally. Can be effective and can be done in conjunction with embolization if it by itself is not effective. And then, of course, there are, the surgical way of managing this is actually suturing the whole uterus with these large sort of compressing sutures that just squeeze the uterus. I think that would be sort of, that would be the last stitch that would happen probably after embolization is tried and failed. And then previously, arterial ligation was performed intraoperatively, but the endovascular approach for achieving essentially the same thing has become more commonplace. And you can just see here, there's a study that sort of looked at, in comparison, what the success rates are. And you can just see that endovascular embolization has a success rate that is on par with the other types of intervention available. And this we talked about already. If we're dealing with uterine rupture or bladder injury, then surgical management is certainly preferred. But if not, then endovascular management should be first line. So I'd like to review some pelvic arterial anatomy. So this is a diagram that shows us in very, just basic, a very basic schematic of the pelvic arterial tree. So of course the iliolumbar, the lateral sacral, and the superior gluteal are branches of the posterior division of the internal iliac artery, and the remaining branches are the anterior division. The uterine artery is a branch of the anterior division of the internal iliac artery, and it often is a primary branch, but it can have certain variations. Less commonly, maybe it'll come off of the internal pudendal or off of the obturator. It's unusual. So when performing an angiogram to look for the uterine artery, we typically do a pelvic angiogram and AP projection to sort of establish where for example, the internal iliac artery origin is. But then in order to clarify the uterine artery origin, we typically perform an angiogram in the contralateral oblique position. And so the uterine artery itself, I'll show you a better example of it on the next slide, is a very distinctive looking artery. It has this U-shaped course, and these are sort of like the typical curves that you'll see on the artery. It has a very characteristic appearance. It typically terminates in this sort of spiral branch. And the location at which you're embolizing, and I'll go into that later as well, doesn't really matter in the setting of hemorrhage. If we're talking about an acute hemorrhage, if we're talking about, this procedure is often also done for the treatment of fibroids. And in those cases, we do take care to subselect the uterine artery and place a microcatheter, oftentimes very deeply in the vessel, so that it is past specifically the cervical vaginal branches if they are identified, in order to prevent non-target embolization to the vagina. And again, there are other branches it's not just the uterine artery that provides supply to the uterus. You do have other arteries, but they're less commonly implicated. And honestly, in the setting of hemorrhage, it is not uncommon to just embolize directly from the internal iliac itself. just take out the entire hypogastric artery instead of sort of subselecting the uterine artery, in which case you would deal with all of these collaterals as well. So when dealing with a patient who you suspect has postpartum hemorrhage, it's better to intervene as soon as possible, because these women, despite compensating well initially, may develop DIC rather quickly from a combination of spasm and low intravascular volume. And so you do want to move as quickly as you can. One caveat being that prostaglandins that are administered to help reduce uterine atony can induce spasm of the uterine artery. And so there should, if you can wait for that to sort of be processed, then you should. That's not, I've never, this is more of a theoretical concern. I've never really had this be an issue. I will say that when you're doing your angiography for uterine hemorrhage, it's very rare to actually identify bleeding vessels. You're not typically going to see active extravasation on the pelvic angiogram. Some studies that looked at that, reported a range of active bleeding extravasation on angiography as being somewhere between 33 to 52% of the time. The one caveat being, if we're dealing with secondary hemorrhage and we're dealing with for example, pseudoaneurysm or just traumatic injury to one of the branches of the uterine artery following either traumatic vaginal or cesarean delivery, you may actually see active extravasation to help guide you. The procedure can be done via both femoral or radial access, femoral access being far and away the more common way of approaching this. Typically what's done is a 5 French sheath and a 5 French system is overall used. A 4 French system can also be used. These are smaller catheters, may be more effective when dealing with a woman who is actively hemorrhaging where the vessels are clamping down. It's not necessary to use microcatheters in the setting of hemorrhage unless you are trying to specifically embolize a certain branch in the setting of, for example, pseudoaneurysm. A Cobra catheter is perfectly sufficient to catheterize the internal iliac artery, and then even the uterine artery specifically. I have also found great success using the Rook catheter. The other method of embolization is via radial access. It just depends on operator. So, the other way of a steam catheter, a long Berenstein catheter, to catheterize the internal iliac and then the uterine artery. It's a very safe alternative to femoral access. So again, you want to treat both uterine branches or both hypogastric arteries when dealing with hemorrhage, and that's because there are cross-sided anastomoses between both of the uterine arteries. It's you can, when you embolize one, you will be reaching the other, but you do want to embolize both. The most common embolic agent used in this setting for this particular indication would be gel foam, because gel foam is a temporary embolic. You can expect it to recanalize over the course of, usually 6 to 8 weeks. When you're dealing with gel foam, you can also take the liberty of doing a more proximal embolization. So in the setting of hemorrhage, it is perfectly appropriate to do an embolization from the hypogastric artery. You can use either pledgets or slurry. I've used both. There is a concern for uterine necrosis if you're embolizing more deeply with, sort of a more liquid gel foam slurry. However, I've never encountered that being an issue. You can use beads to treat this as well. That's very commonly done for fibroid embolization when doing uterine artery embolization. In the setting of hemorrhage, it's probably not. I mean, you can, if you can get purchase into the uterine artery, you can also use beads. Cyanoacrylate or glue is another liquid embolic that can be used. It's very effective, especially in the setting of severe coagulopathy, because it doesn't rely on the coagulation cascade, but rather just fills up the space. It's very effective for pseudoaneurysm embolization, but would require the use of a microcatheter. I would not use cyanoacrylate through the base catheter. Coils are typically not needed, but can be used. I would say that that's probably the least commonly used embolic. I would probably stick with gel foam for the indication of hemorrhage. Right. I mean, so pseudoaneurysms are, you know, like when we're dealing with secondary postpartum hemorrhage, I think it does behoove you to, if you do see it, to get selective as much as you can and embolize with a more aggressive embolic agent such as coils or glue. When you're doing your completion angiogram, you should really have as long a delay as possible in order to look for collateral flow. But if you're embolizing from the hypogastric artery, you're usually taking care of it. The other way of sort of providing endovascular management for women who have postpartum hemorrhage is in the setting of, well, you know, in certain cases, like for example, with placental abruption, with placental attachment abnormalities, you usually know this ahead of time. You know, if the woman has had any, pre-delivery, ultrasounds, you can typically say that this woman, if someone has placenta accreta or procreta, they are certainly at a higher risk of developing postpartum hemorrhage simply because of because of that abnormal placentation. And so for those women, it is possible to place balloons into the iliac artery ahead of time. Just, get bilateral femoral access, place these balloons, not necessarily inflate them, but have them ready to inflate, so that while delivery is occurring, in case they encounter hemorrhage, you can provide sort of immediate hemorrhage control. I will say that this is pretty rarely done nowadays. I think that it is a good option if you can plan ahead. Most commonly, like for when I have these referrals, I typically just we just make ourselves available. So when the delivery is occurring, if there's any risk of that, we can just go into the OR and do an embolization at that time. We don't typically place balloons ahead of time. There is some concern for these balloons becoming, damaging the vessel, so you don't really necessarily want to place them unless they're needed. But there's no right or wrong with this. This just sort of reiterates that the American College of Obstetricians and Gynecologists does not, really support the use of balloons as a prophylactic measure against postpartum hemorrhage for women with abnormal placentation or with otherwise a high risk of postpartum hemorrhage. But it has been done, and it has been done with good success. So just to review some of outcomes, both positive and negative, the success rate of uterine artery embolization for the indication of obstetrical hemorrhage is very high, in the range of over 86% success rate, with uterine atony being the most common cause. In the setting of genital tract trauma, it's still very effective, very much lower cohort of patients, but it can provide enough of a bleeding control to provide space and time for the OBGYN to, kind of perform the suturing necessary or to make the repairs necessary to provide, definitive management. And then, of course, like we were talking about for patients with abnormal placentation, they respond to embolization of up to 80% of cases. This is a little bit more challenging because the placenta itself, because it's so deeply invaginated, especially in the setting of accreta, that sometimes it's just not possible to provide adequate control, and these women ultimately require hysterectomy anyway. So for in the setting, if the embolization doesn't work, there are a few things that we can say that perhaps are, contributing factors. If the woman is a little bit older, if the patient is in severe DIC, such that the embolic that we're using is not really effective. If the woman has had C-section just being sort of an overall risk factor for both bleeding and, treatment-associated failures. And like we discussed, placental attachment abnormalities are often associated, not often, but it can be, endovascular management may not be particularly effective in patients with abnormal placentation. Additionally, if the patient is in severe shock, especially if that leads to vessel spasm, if you're not able to get good purchase into the vessels that you need to embolize, it can, limit how effective the embolization is. And then, again, like we discussed, we should move as quickly as possible when dealing with these types of patients in order to be as effective as possible. So the complication rate associated with endovascular embolization for hemorrhage is very low. We're talking mostly minor complications. So these include access site hematoma, dissection of the uterine artery, which is not something that we have to, try to repair. This usually sort of self-resolves, or even if you lose access to that uterine artery, it's not the biggest deal. You can develop transient sciatic nerve paresis, especially if you're embolizing more proximally. And more major complications would be extremely rare. So uterine necrosis requiring hysterectomy would be one theoretical concern. I've never heard of that. It's pretty it would be exceedingly rare. Non-target embolization is something that you should be mindful of, even if you're doing an embolization for an an emergency indication. You should take very careful. You should be very careful about not allowing any of your embolic to enter the external iliac. For example, you don't want to have non-target embolization down the leg. We do warn our patients about bladder claudication following this procedure, because that can occur. We're using limited and resolve. So, and then bladder necrosis again include. So, follow up after performing this procedure, you should be, I typically give these women, and they're probably already receiving this, but a 7-day course of antibiotics just to mitigate against endometritis or infectoma, because we're dealing with sort of a mixture of both open and closed procedures. And then at the end, I just wanted to, just briefly discuss what data we have to concerns or fertility following avoid a hysterectomy. This is not so afterwards impact their fertility, and so I just included 2 studies here that look at that specifically. So this is a survey-based study looking at just small cohort of women, about 33 women, who were treated with arterial embolization after medical management of postpartum hemorrhage had failed. So of the women who were available for the follow-up interview, 91% of them had regular menses. And a large group, a large number of them actually had no desire for additional pregnancy. 2 of the women who attempted pregnancy did not get pregnant because of the causes listed here specifically, potentially age or potentially male infertility, and for her specific situation. But 13 of the women who, out of this group did have successful pregnancies. And so it's a really difficult thing to track because it sort of depends on the woman's desire to, to have a pregnancy afterwards. But what it seems like is that most women have normal menses after uterine artery hemorrhage, and therefore, if they desire to get pregnant, there's really no indication that they would not be able to. And again, this is another study. This is actually a review of studies looking at 13 individual studies about embolization outcomes with respect to fertility. There are a total of 168 women. And not only did it discuss the success of embolization, which was, over 90%, there were 45 pregnancies within this cohort of a total of 168 women, of which 71% were successful without complications. A few of these women did have postpartum hemorrhage again, and so some of them did fine with conservative management. 1 was re-embolized, 2 had hysterectomies. But again, that sort of, I think that also is in line with the idea that pregnancy. But again, this study just does overall tell us that women who desire to have pregnancies following a uterine artery embolization may very well be successful. There's no indication that they wouldn't be. Just most women, the takeaway here should be that most women following uterine artery embolization have normal menses following the procedure. And then overall, what we discussed today, postpartum hemorrhage is a very common or a very severe cause of maternal death, and can be caused by a number of things, most commonly caused by uterine atony, but can also be caused by either uterine or general tract trauma, either iatrogenic or not, can be caused by abnormal placentation, or can be, associated with a severe coagulopathy. The uterine arteries are branches of the anterior division of the internal iliac artery, and most interventions can be performed via the base catheter from the level of the internal iliac artery when dealing with hemorrhage. And most commonly, we use gel foam as our embolic agent of choice because it is temporary and it is effective. This is also just sort of reviewing some of the things that we've already discussed. embolization is extremely effective for this group of women. It is a minimally invasive option, and so it can be less morbid than potentially doing uterine, ligation, or uterine, like the large sutures in the uterus, or it can be more effective than, or maybe less morbid than doing a hysterectomy. There is, we always talk about transient ovarian failure or permanent ovarian failure in women following uterine artery embolization. It's typically related to non-target embolization, but that's usually when we're talking about a more specific, more permanent embolic agent, and would be the result of, I mean, you can see where you're going. It's very unlikely. You're very unlikely to cause that, and most women have normal menses afterwards. So that concludes everything that I wanted. Very much for inviting me to speak here. If there are questions, I'm happy to answer them. I know this is not, this doesn't cover everything, but I'm hoping that it does give us an overview.
Thank you, Dr. Sarah, for your nice and elaborate presentation. I'm Dr. Vishwajit Bhomik. I'm working in Bangladesh, and I'm Scientific Secretary of Bangladesh Society of Radiology and Imaging. So actually in Bangladesh, only few of us are doing interventional, actually endovascular procedure for gynecological and obstetric management. So your lecture, I think it will very much helpful for us for further intervention and doing in the endovascular procedures for gynecological and obstetrical emergencies. So actually, I have one question. So actually, so during injection of gel foam,
yes.
So actually, the gel foam should be mixed with contrast. So actually, how should I inject? Actually, how long? So should I check the complete stasis of the gel foam? So can
That's a great question. I usually, so I mix it with contrast. Usually, I don't know how your gel foam is available to you. There are a lot of different forms. Typically, it comes in this little sheet that you cut up, and then you mix with contrast to create this slurry just by sort of using 2 syringes and mixing it back and forth, and it creates sort of this like I wouldn't make it too liquidy. I wouldn't make it too solid. You want it to be thin enough that it's going to move through your catheter easily. I usually perform gel foam embolization to stasis in the setting of hemorrhage. And so if I can get into the uterine artery itself, then yeah, I will take it out to the point where when you do your completion angiogram, you're only seeing sort of the very, very proximal portion of that artery. If I'm performing it if I'm embolizing the hypogastric artery, sort of a more proximal embolization, that is I usually look for pruning of the vessels, that you can sort of, there's no like amount necessarily, just every patient is a little bit different. But I would embolize to like, maybe 5 beat stasis, something, 4 or 5 beat stasis.
Okay. So we have to wait up to the complete stasis of the uterine artery.
I would, if you have catheterized a uterine artery, then yes, I would embolize to stasis. If you have catheterized the hypogastric artery, you can probably be less aggressive, but nonetheless, I would still embolize until I'm seeing 4 to 5 beat stasis from the hypogastric as well. It's harder to know. Yeah, it's harder to know what the uterine is doing when you're embolizing from more proximally, just because you're not going to see filling.
Thank you, Dr. Sarah. Many thanks.
You're welcome.
Uh, can I, hello?
Hello.
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 Okay, thank you, Sarah. I am Dr. Shirin from Medical University of Bangladesh. So first of all, I want to give you the thanks for excellent and informative presentation. But I have a question to you that you already showed that some of the patient may have developed ovarian failure. So I want to just know that do you have any specific study or data for the patient who already who may have the developed permanent ovarian failure or secondary infertility, especially it is very important if the patient is primary, right? So do you have in such type of any data, or do you know anything that who or how many percentage develop permanent infertility or ovarian failure after doing that endovascular intervention?
I mean, that's a good question. I don't know that that this is something that's like, it's hard to know because the cohort of women that are being embolized for postpartum hemorrhage are obviously younger. And so the majority of the data that's looking at uterine artery embolization is looking at women with fibroids, and typically they're being embolized in their 40s or older. So they're looking at women who are perimenopausal or approaching menopause. And so for those women, the rate of premature ovarian failure is low. We're talking about less than 5%, but that again is in a cohort of women that is already closer to menopause, and so they have a higher risk of developing menopause after the procedure itself. I would imagine that it's much lower in this cohort of women who are obviously going to be younger, but I don't have that data.
Okay, thank you very much.
Hello, Sarah.
Hello.
I'm Zair from Combined Military Hospital. Probably you were preferred to, approach through radial axis. So if I prefer for the RFA or LFA femoral axis, then what do you suggest for if I suspect unilateral hemorrhage, unilateral uterine artery hemorrhage, then do you suggest just I can puncture in opposite side femoral artery or bilateral? What do you say?
So in order to treat either unilateral or bilateral, you can have single femoral artery access. That's fine. I would say that if you're suspecting unilateral uterine artery hemorrhage, you're probably thinking of secondary PPH related to a pseudoaneurysm. So you're going to hopefully know ahead of time where your vessel is, but you can be ipsy or contralateral and be able to reach it.
So I think if I puncture bilaterally, so there will be more
access for both. It doesn't make you faster, not necessarily, because the time of puncture is going to add to, just sort of embolizing on one side and then pulling your catheter back and then embolizing on the other side.
Okay, and what about the alternative than the gel foam? If I suspect, probably during the emergency, we might not have that. Options to go for the any coagulopathies or not. Then what would be the alternative for gel foam?
I would use beads.
What do you suggest? Can I use onyx or even glue?
Glue. So glue and onyx are great embolic agents, especially for women who have severe coagulopathy. But I would not use them in the like you would have to get selective. So I would embolize only from the, like I would get into the transverse portion of the uterine artery and then embolize from there using a microcatheter if I was going to be using glue or onyx. Just because the long-term sequelae of non-target embolization with either one of those agents is far more severe than with gel foam.
So thank you. And one last but not the least, sort of personal question. How long you are doing this endovascular intervention?
2 years.
3 years?
2.
Okay. 2 years. Okay, thank you.
You're welcome. Any other questions? All right, well, thank you again for inviting me to speak here. I had a great time.
Thank you, Sarah from Bangladesh.
You're welcome. Hi. So if there are any questions that I can answer offline, I'm happy to share my contact information. And yeah,
Thank you so much, Dr. Kantharia, for the wonderful presentation and answering everyone's questions. Again, and if anyone has any further questions you think of later, you can also email me and I'll make sure to get them to her and make the connection for you. I just wanted to check because I believe our colleagues at BSRI wanted to make a little announcement about future webinars, perhaps. Dr. Palash, did you have anything else you wanted to add?
Sorry, I'm here. I'm Palash. Yes.
Hi, I just wasn't. I just wanted to make sure you didn't have anything else you wanted to announce or about.
Okay. So actually, so I hope we can do another webinar in the next month. So maybe we can do so this type of webinar every month. I think it will be very much helpful for us. And thank you. Thank you. Actually, we will contact with Dr. Jia and also will contact you for further webinar related procedures. Okay.
Yes, yes.
Many thanks.
We are happy to continue to host. In fact, I think we have a speaker lined up for next month already, and she's going to be talking about MRI safety. So I will get more details and we'll work on a date and get it out to all your members.
Thank you. Many thanks.
Wonderful. Well, everyone, please have a great evening, and I'll look forward to speaking with you next month.
Thank you. See you. See you in next month. Bye.
Thank you. Thank you, Michelle. Thank you, Sarah.
Thanks, Ia.